So some of the common cases that we come through in OPD, a 64-year-old patient with 16-year history of persistent dry cough in the absence of wheezing, shortness of breath or excessive sputum production, coughing most of the days with no seasonal changes or obvious provoking factors. Medical history was significant for erosive esophagitis, which is documented by endoscopy, for which the patient was started on a PPI, but did not help her, and she discontinued treatment after 3 months. She has been ongoing on aspirin 75 milligrams daily, despite having gastroesophageal reflux and asthma. Spirometry, as you see, this is the most common thing. With the FEV1 is 82%. Most people just won't get a post-bronchodilator test done, but please get it done. Here, if you see that the FEV1 was 82% and post-treatment was 93%, with a 13% change from baseline and more than 200 ml increase in FEV1, gives you a cough variant asthma history. So GERD, only treating GERD would not help. Here, a combined formoterol budesonide inhaler has helped the patient significantly, and optimizing the GERD symptoms has helped the patient significantly. So therefore, this is a combination of GERD and a cough variant asthma, and you can only treat them when you are following a protocol and seeing what is causing the patient a problem. Now, GERD-associated chronic cough in another young patient who presented with atypical pneumonia, where a diagnosis of asthma was made and budesonide inhaler was given. In a 13-year-old, you don't suspect GERD. So this patient's wheezing resolved, the cough only resolved partially and persisted. So this is very typical that as soon as you've given the inhaler, the patient in 4 weeks' time starts finding benefit in their breathing, but the cough still persists. And this time, again, 3 months later, she was presented due to exacerbation of coughing. Here, bronchial reversibility was negative, pulmonary function test was normal, and peak flow was good. Here, again, in addition to budesonide, adding a beta-2 agonist did not help the patient at all. This time, somebody looked at the patient and saw she was obese. She was complaining of frequent belching and had a significant weight gain in the past few months. And her cough was predominant in the daytime and deteriorated when she rose from bed and after eating. So here, a frequency scale of symptoms of gastroesophageal reflux score was done, and her points came out at 9, the normal reference value being 8 points. So this time, we referred the patient to the gastroenterologist, and the gastroenterologist showed that the 24-hour esophageal pH monitoring showed significant acid reflux. And adding a proper PPI actually helped this patient, not just asthma alone. And these two cases are cases that will form a significant proportion of patients that visit your clinic for cough, and therefore discussion. So managed with a PPI, and eventually after 4 weeks, you reassess the FSSG score, which significantly shows improvement.